Thank you very much. Thyroid eye diseases. So you are welcome, ma'am, and you can proceed as soon as you're ready, ma'am. Apologies for the late start. Thank you.
Apologies, all mine. Sorry. Am I audible?
Yes, you are very audible. Please go ahead, ma'am.
Okay, I had to adjust that. Okay, am I audible?
Yes, you are very audible now.
Okay.
We can hear you.
Okay. Good afternoon, everybody. Thank you for having me. This afternoon, we are going to talk about the management of thyroid eye disease, and I apologize for the slight hitch we just experienced. We had to suddenly change our system after getting everything all set. Thank you very much. So we're talking about management of thyroid eye disease. And as we are well aware, thyroid eye disease is an autoimmune inflammatory disorder that involves the orbit. And a large percentage of patients who have thyroid eye disease have Graves' orbitopathy are actually hyperthyroid, as close to 85 to 90% of them. And many patients who develop thyroid eye disease from thyroid anomaly, Graves' disease with orbit complications usually develop this orbit features within 8 to 12 months of the autoimmune dysfunction of the thyroid gland. Several names, the disease goes by several names and appellations: Graves' orbitopathy, thyroid associated orbitopathy, thyroid eye disease, are all referring to the same condition. I believe I'm audible, right?
Yes, you are. Please go ahead, ma'am.
Yes, thank you very much. And the disease is an autoimmune attack to which the thyroid skin are all subject to varying extents. And there are several mechanisms that are involved in causation of it. A lot of studies have gone into the different pathogenetic mechanisms, ranging from cellular immunity, various molecular pathways, role of hyaluronic acid, adipogenesis, oxidative stress, fibroblastic response, autoantigens, and the like. And the outcome of all this is an increase in the orbital pressure, an increase in a reduction in venous outflow with congestion and chronic periorbital edema. And at the early stage, you have inflammation and congestion, which later is followed by fibrosis at the later stage of the disease. And it's said that the orbital fibroblasts are the key effector cell of this dysregulated normal function that we see in the orbit. And it plays a key role, that's the orbital fibroblast, in orbital inflammation that occurs, and tissue expansion, remodeling, and fibrosis. And this is from the increased proliferative activity that is seen, and the capacity of the orbital fibroblast to differentiate into adipocytes and myofibrils, and increase in glycose aminoglycans production. And this mechanisms also cause an interaction with mononuclear cells, producing various substances like cytokines and other chemoattractants, which ensure and perpetuate the inflammatory reactions. And then you have extraocular muscle deposition of hyaluronic acid, chondroitin, dermatan sulfate, increased collagen, and these are anionic and they are hydrophilic. So it causes fluid to be imbibed with edema of muscle, atrophy of muscle bundles and extension of fibrous tissue into the adjacent adipose tissues. And this is what we see at the inactive phase of the disease. We'll talk about more about this as we go on. The disease is actually self-limiting. It burns itself out after a while. And like I mentioned earlier, up to 85 to 90% of patients are hyperthyroid. It's a very small percentage, about 10% of them are hypothyroid, while 5% of them, are euthyroid patients. It's said that about 40% of patients which have 40% of patients with thyroid eye disease simultaneously have ocular and systemic features. And this schema just shows at a glance the systemic features that these patients will have, ranging from the eye features, exophthalmos, and the like, to increased sweating, and of course the presence of a goiter, and cardiovascular effects like arrhythmia, tachycardia. Patients have general effects, headaches, weight loss, nervousness, emotional stability, increased autonomic changes, nausea, diarrhea, and you have menstrual and gynecological abnormalities in females, muscle wasting, and fine tremors in them as well. And the course of the disease, it runs, you have an initial acute inflammatory phase, which ascends to a maximum and gets to a static plateau phase with later fibrosis, but it does not come to the baseline. Now, this curve is known as the Rondel's curve. And in the course of the presentation, we're going to talk more about it and what it means, in the overall management of the disease and the specific giving this, collecting the symptoms from the patients and eliciting the signs, and what are the investigations we are going to do, and the various treatments that are available. So the patient will may come with a complaint of a red eye, a protrusion, double vision, dry, gritty feeling, pain. There may be pain at rest or pain of movement, and there'll be cosmetic changes. Now, the patients present with a wide range of symptoms, from the seemingly mild to the quite severe. And in fact, you'll be surprised how often patients with thyroid eye disease may be misdiagnosed with other external eye conditions. Be surprised, allergic conjunctivitis and the like, because of the subtle features they may have. And when we think of thyroid eye disease, first thing we think of is the proptosis and all the cosmetic changes, and the patient may not necessarily come with such overt features, and those things might actually be surprisingly misdiagnosed. So the signs we see when we examine the patient, the lid retraction is the most common. And of course, it gives the staring appearance of the patient when you have the lid margin that extends beyond the upper, the normal level where the lid rests, which is about 2 millimeters from the superior limbus and at the inferior limbus. It gives the appearance of a staring gaze. Proptosis, protrusion of the globe anteriorly, is the next most common presentation, occurring about 60% of patients. And lid lag, where the downward gaze, as the globe rotates inferiorly, there is a lag of the lid following the globe. And chemosis as well. In addition, you can have other features like periorbital swelling and keratopathy. These are late or maybe neglected cases, as the case may be. Other features that may be elicited: orbital fat prolapse, conjunctival injection, and anterior segment examination. Other anterior segment examination may show relative afferent pupillary defect. There may be a differential IOP. This is just one of the features we elicit when you take the IOP in the straight primary position, and then with the patient gazing upwards, just to demonstrate the restriction that the muscles would have had. Also, optic neuropathy may be elicited in these patients. So general examination may show a neck mass and further examination of the musculoskeletal system, as you can see in these pictures, they show thyroid acropathy, the characteristic digital effects you may have, and you might have a pre-tibial mixed edema. Am I still audible?
Yes.
Okay, thank you very much. Cardiovascular examination is also very important in this patient. It's very important. You'll be able to demonstrate an irregular pulse, systolic hypertension, or even cardiac abnormalities, you know, that will be a sequelae to this. So in investigating these patients, we're doing thyroid function tests, and this includes the assessment of an assay of the thyroid stimulating hormone and the blood serum levels of the T3 and T4 levels. It's also important to assess measure the assay of the thyroid receptor antibody levels and the thyroid stimulating immunoglobulins. The TRAB, that's the thyroid receptor antibody levels, are important because they help to not just confirm the diagnosis, they also give a measure of the severity, because their presence and their level and their titer are an important risk factor for visual loss, you know, or the presence, a predictive value for visual loss, and monitoring treatment response in these patients. Other markers for thyroid autoimmunity, you know, can be done. Their assays can be done, including anti-thyroglobulin antibodies, anti-thyroidal peroxidase antibodies, and anti-sodium iodide symptom antibody can be assessed as well. Imaging is very important in assessing these patients, and it's very important in a differential diagnosis. It's important in the interdisciplinary management of the patient. This is one condition, we're going to talk about that, where you have the role for synergistic support for several disciplines, and CT and MRI are the more common imaging techniques. So what are the indications for CT in thyroid eye disease? If you have an unclear asymmetric proptosis, you want to do a CT scan. It's still said that thyroid eye disease still remains the most common cause of proptosis, unilateral or bilateral proptosis in adults. Sometimes the proptosis may be asymmetric, may be unilateral, and the symptomatology and the clinical features may not exactly pinpoint to something. So this is an indication for CT. When there's suspected optic neuropathy in a patient, when the diagnosis is uncertain and MRI is unavailable, and of course when the diagnosis has been confirmed, patient is being managed, and you are preparing for orbital decompression, CT is a must. And CT actually shows actual objective morphological findings, and CT findings are correlated with the clinical features and features of extraocular muscle enlargement. And indeed, when the clinical features may be unilateral in the patient, 75% of cases would actually have bilateral CT findings to further confirm your diagnosis. So what do we see on the CT scan? You see muscle enlargement with a typical spindle shape which spare the tendon and may impinge on the optic nerve. But actually, new studies have actually found out that the traditional thinking that in thyroid eye disease, the tendons are spared, that thinking is being seriously challenged now. And in some cases, it has actually been found that in thyroid eye disease, contrary to traditional thinking, seeing muscle enlargement with the tendons not spared still does not rule out thyroid eye disease. So that's the thinking from some studies now and some observations that have been made now. So in as much as we expect usually the tendon to be spared, but that the tendon not spared does not rule out thyroid eye disease. And of course, crowded orbital apex with optic nerve compression, as this picture will show. This is supposed to be the area of the optic canal, and we can see that there's definitely this muscle enlargement here impinging on the optic nerve. Okay, it's also possible to see enlarged them, to appreciate enlarged orbital fat. And because of the, especially when you have bilateral enlargement of the medial recti muscles, you can actually have slight bowing of the medial orbital wall. And it's not surprising. Remember, the medial orbital wall is the lamina papyracea, which is just paper thin. You know, so when you have like what we're seeing here, a marked enlargement of the medial rectus, you can actually have a medial bowing, you know, giving like a bottle sign configuration for the medial orbital wall. And this also shows marked enlargement of the muscles. This is at the towards the orbital apex, and this is the coronal view. This is an axial view, and this is the coronal view of the seat of the orbit. With all these features, it's also important to know that there's an absence of a space occupying intraorbital process. That means you are seeing masses, you're seeing orbital, maybe muscle enlargement, increased fat, but you can't actually pick out a tumor mass per se. For axial scans that are more superior, just before the equator of the globe, you might appreciate it's possible to see an enlarged superior ophthalmic vein enlarged. And also, these are one of the features that the radiologist may report. It might not be so obvious to us here. The abrupt angulation of the posterior muscle belly and intraconal fat prolapse. These are all radiological features of thyroid eye disease that we may see on the CT. And indeed, when we do inferior axial scans, at the inferior, that means you have gone below the level of the globe, but it's still an axial scan. An enlarged inferior rectus muscle may simulate an orbital neoplasm. So what happens with an MRI scan? It's used in thyroid eye disease with decreased visual acuity to detect compressive optic neuropathy. Actually, the CT scan and the MRI are synergistic, and it's said that MRI usually is superior in detecting lesions of the optic nerve. And when there's an intervention choice between medical and surgical course of treatment, and it's uncertain, one we want to do an MRI to further confirm whether there are features that are suggestive of optic neuropathy, subtle as it may. And once again, when the diagnosis is uncertain, and in patients who are euthyroid and they have normal thyroid function test, and we have to further evaluate, an MRI is called for. And it's important for an MRI because it's able to delineate inflammation from fibrotic, than, you know, that's the stage of inflammation of the disease from the stage of fibrotic. Because this, as we go along the line, we're able to see that this calls for different kinds of therapy. So we say MRI can better delineate that than the clinical evaluation. And it's advised that in the course of the treatment, serial investigation with MRI can be done to monitor progress. So how do we treat thyroid eye disease? One thing we must bear in mind is that thyroid eye disease is a raging inferno in the orbit. It is a house on fire. It is a house on fire. And when you want to deal with a house on fire, you first put out the fire. Even if you're going to have to build from ground zero, you have to put out the fire. The place has to be quiescent before you start to build. So the principle of treatment is that you put out the fire. In other words, you deal with the acute inflammation, congestion, and all the things that make you angry, and then you start to build. So we'll remember that you put out the fire, then we build. So like I said, it's a raging inferno. You start to build. So you are now when you get to the patient, it's like you want to ask, where in the course of the disease is this patient that presents at? Because it's important to know that the disease course in different patients actually is individualized for every patient. While we say that generally the disease should burn itself out for most patients between 3 to 5 years, how they run that course is now unique for each patient. And you want to get for that particular patient where in his disease he is at. So we're talking again back to the Rondel's curve, and our aim is to shorten that curve and to flatten it. Let's see how we do that. So look at again at this Rondel's curve. This shows the severity, and this is the time course. So we have the inflammation increasing to a crescent, and then to a crescendo, and finally gets to a static phase, which doesn't go down to baseline usually. And at this point, you start to have the fibrotic stage. So we can break down that rhondoscope into the two parts, activity and severity. Activity refers to inflammation, the fire, the rage, the inferno, and while severity is a function of the degree of, it's a function of how much function has been lost by the eye, degree of diplopia, soft tissue changes, and the impact on the quality of life of the patient. So you can actually break the rhondoscope like this and see that actually the activity, which refers to the inflammation, actually does rise to a crescendo and can come down. Now we're talking about this severity, which is now marked later on by fibrosis. That is what actually we see that may not come down to baseline level. And that's when we start having to build, because the fire has, so to speak, burnt itself out. But we now need to now deal with the issues that are remaining, the ashes. How do we start to build, and how do we start to deal with the impact on the quality of life of this patient? So this is just breaking down and explaining the rhondoscope. So we say our aim for treatment is to flatten the curve, and so is to flatten it. So we don't want the activity to go so high. If we can bring it down before it gets this low, we are flattening the curve and we are shortening it, so it doesn't have to get to God knows how many years, and we can shorten the time it will take. So this is what intervention will do. So if this was the cause of the treatment, can we do something to make it come down, to flatten it, and to shorten it? So that's just what the disease time course and intervention would do for this patient. So like I said, the course of disease for each patient is actually different. It is tailored to consider all these factors that are separate for each patient. We're talking about the differential cause. We're talking about there are issues that come in the ocular surface. There are issues that have to do with inflammation and clinical activity of the disease. There are issues that have to deal with quality of life assessment, and there are issues that deal with functional issues, loss, for example, like strabismus and the like. Functional issues have to deal with severity of the disease. So this brings us to the third patient is at the center of a multidisciplinary specialist action. Hitherto we talked about the patient having a step ladder. He comes to the general physician. Then if the disease is more serious, he goes back to the general ophthalmologist. Then he goes to right now the trend is the patient is at the center of it all. And we know around you have the general surgeon, you have the nuclear physician that is ready, you have the endocrinologist, you have the general ophthalmologist, you have the orbital and strabismus surgeon, you have the general physician, and you have the pathologist. All of them, all creating a kind of thyroid unit. And in some specialized centers, you actually have a thyroid unit where you have the patient coming. When the patient comes for consultation, he actually gets to have the opportunity to see everybody. So everybody could see, where is he at? The nuclear physician, is it at this point we need to give this patient radiation? What are we doing for him? The general surgeon, the orbital strabismus surgeon, and the like. Is it at this point he needs XYZ intervention and all that? So he is at the center of a multidisciplinary team of experts. And this is the best offer that we can give for our patients, knowing fully well that this is a condition that affects beyond the clinical things we see. There are the quality of life assessments that may not be so obvious for the patient, and we must recognize that the patient we must avail our patient of the expertise assessment in thyroid eye disease patients is significant. Many third patients are unhappy. And this may not reflect our clinical impression of disease activity or severity. It comes to the clinic, we check in, clinical activity is XYZ, severity is XYZ. Okay, want to take this, want to take that, want to take that, we go. But the patient is not a happy patient, and we've gone beyond, this is what we are going to do for this eye. We're thinking of what are we going to do for this patient as a patient. And it's been assessed that quality of life scores in thyroid eye disease patients has been found to be lower than those do have diabetic mellitus, emphysema, or heart failure. This is important because there are a lot of psychosocial issues that have to deal with this. You know, the patient, oh, the patient is not clinically, we might say this disease is not severe, it's just mild and all that. But meanwhile, the patient is already dealing with a loss, it's a stigma, with a loss of social standing, with a loss of maybe social economic strength, you know, and capacity reduced. So these are things that we are considering when we're talking about quality of life, and we should have that, you know, in our consideration of management for this patient as a total management package. And know that these are the patients that we might say, if we have the social support system in our hospitals, and patients will avail themselves on that. Sometimes this is not the first patient you would think of when you think of social services. You're thinking of the patient who probably an abandoned child or something. So this is just to draw our mind to that social support is very important for these patients. So this is just to show the quality of life assessment form, which is used in the UK. So there are various treatment classifications, disease classifications for these patients, and they are all tailored to be able to achieve increasingly superior treatment for the patients. And various classifications have been used, you know, in the past and now being modified by, you know, the ability to translate these classifications into a clinical picture dealing with the pathology and the appropriate treatment for the patient based on the staging that is being used. So we talk about the NOSPECS, the VISA, and the UGOGO. The NOSPECS had been used in time past, and here we talk about only signs, sorry, N standing for no signs, as we are well aware. Only signs, that's referring to lead retraction and lead lag. The soft tissue changes that we see, edema, chemosis, proptosis, extraocular motility. The C referring to corneal exposure, and S sight loss, which might be from this thyroid optic neuropathy or blindness from corneal exposure, coincident on blindness from corneal exposure. So I talked about this. UGOGO just refers to the European group on Graves' orbitopathy, and that's the classification that has gained superiority in the past couple of years. And the VISTA classification just refers to visual acuity, inflammation, strabismus, and appearance of the patients. Am I still audible?
Yes, please.
Yes.
So the clinical activity score actually demonstrates pathology of inflammation. It demonstrates pathology of inflammation. We're taking advantage of all the features of inflammation that we know: redness, warmth, pain, swelling, and loss of function. And this classification system, which has been used by the European group and has been validated over time, and then it's now being used in the current management of this condition, actually talks about the clinical activity score for the patient. Is able to differentiate the patient who's having inflammation, differentiate the inflammation from the later stage of the disease where you have fibrosis and buildup. So it's a validated scoring system. It differentiates inflamed from non-inflamed, and it has a high predictive value for outcome of immunosuppressive treatment. So we can use it to guide the kind of treatment we are giving, at what point we are giving what treatment. So what are the features of the clinical activity score? Remember, we are talking about it's based on features of inflammation: redness, warmth, pain, swelling, and loss of function. So it has 10 criteria. And at the first visit of the patient, we can only use 7 criteria. And these include swelling of the lids, swelling of the conjunctiva, swelling of the caruncle. So that's swelling, okay? Then redness of the lid, redness of the conjunctiva, and pain either pain at rest or pain at eye movement. Can you hear me? Am I audible?
Yes, yes, you are, ma'am.
Oh, thank you very much. So just to explain what we mean by redness of the conjunctiva so that there's no ambiguity. For example, it said that the redness on the conjunctiva is not redness that is assessed at the slit lamp. It's redness that is assessed without the slit lamp. You know, stand the patient at least a meter away. If you can ascertain redness at a 1 quadrant or beyond, then you score a mark. So for each of these, you know, if you can assess, and if any of them is positive, you give a score for each of them. For example, this swelling of the caruncle, redness of the conjunctiva, swelling of the conjunctiva, which is actually chemosis. They are actually based on the pathology. You have increased inflammation, you have congestion, and all those things we talked about earlier. You have congestion at the back, at the orbit, which translates to reduction in venous pressure and venous drainage and increase in pressure. And this is translated at the back, the front of the eye, where you see redness of the caruncle, redness, you know, swelling of the caruncle, and all these other features there. So this correlates with the pathology that is going on at the orbit. So if patient has any of this, you score the patient 1 point. No. So for a patient you are seeing at the first visit, the last 3 parameters, reduce visual acuity, reduce extraocular muscle, and increase proptosis, you cannot score them because they are based on the comparison from a previous visit. So when a patient comes for the first visit, his clinical activity score is scored over 7 points. Okay, so if he comes at a subsequent visit, you can now assess the remaining 3 parameters. Then you can say reduce visual acuity. If visual acuity drops more than 1 Snellen's line, he scores 1. If the extraocular muscle excursion is reduced, you know, significantly, it's said to be about being able to assess it up to about 8 to 10 degrees is 1 point. And if there's increased proptosis compared to a previous visit, you know, it's another point. So if a patient has 3/7 at baseline, anything more than 3/7 at baseline tells you that. Am I still audible?
You are, ma.
Yes, ma'am.
Okay. So if anything more than 3/7 at first visit is considered clinically active, and anything more than 4/10 at a later visit is considered clinically active. So that's for activity. What about severity? Now, we're still talking about treatment. These are the things that guide us to know what treatment we should use and the like. So when severity, we're talking about mild, moderate to severe, or sight-threatening. That's the classification. So in mild disease, you have proptosis, which is less than 3 millimeters above the normal range for the age and sex of that patient. Anything lid retraction that is less than 2 millimeters, and diplopia that is transient or non-existent at all. So with this, most patients that will have this, it's said that they will have a minimum impact to interfere with his daily life. So that's a mild disease. Now this is important because it determines the kind of treatment that the patient is going to have. Moderate to severe, you know, at this point, the patient is said to have no minimal threat to sight because there's at most intermittent or constant diplopia. The lid retraction is more than 2 millimeters and exophthalmos more than 3 mm. Now it's said that if you do not know how to classify a patient, does this patient, since you have mild, you have moderate to severe is one classification, you have sight-threatening. You either assess the patient as mild and sight-threatening. So if the patient is not mild and he's not sight-threatening, he is moderate and to severe. So you have sight-threatening severe stage. So any of these parameters, if the patient has dysthyroid optic neuropathy, you're able to elicit that maybe from compression. If there's a corneal breakdown from exposure, there's globe subluxation, and there's very severe forms of frozen eye, intense chemosis, intense lid swelling and congestion, and they're able to elicit choroidal folds, and patient has postural visual obscurations. This tells you that there's imminent threat of loss of sight. So that's for that classification, and we're going to see how we're going to use that to interpret the treatments that are available for the patient. So talking about the different forms of treatment, you have the general measures, control of risk factors, the local treatments, immunosuppressive treatment, and finally sequential surgery. So while for every patient, we need to be able to control some existing risk factors and put the patient at a better stage to get the benefit of whatever local or systemic treatment he's going to be exposed to. So generally for all patients, every patient that has thyroid eye disease, any patient that has thyroid disease needs to be advised against smoking. And if the patient does not have eye features and the patient is already a smoker, stopping smoking is going to reduce the risk of progression to eye findings. And even if he already has eye finding, smoking will worsen the progression of this eye findings, and it's such a negative risk factor. And it's thought that even when a patient for smokers, their response to immunosuppressive therapy is much reduced. So it's a win-win for any patient not to smoke or to abstain from smoking once thyroid disease has been controlled. It's not surprising, because one of the pathogenetic mechanisms involved in the thyroid eye disease has to do with production of free radicals, which alter the normal redox state of the eye. And it's found that in smoking, a lot of free radicals are produced, and they alter the normal redox status of the body, and then this contributes also to cytokine production and the other pathogenic mechanisms. Thyroid dysfunction, every patient must become euthyroid. So if hyperthyroid or hypothyroid, thyroid dysfunction must be normalized, and the patient made euthyroid. At best, it's advised that the patients, there are different modalities for thyroid control, either surgical excision of the thyroid gland, subtotal or total thyroidectomy, use of radioactive iodine, and use of antithyroid drugs. However, it's normally advised that surgical excision, subtotal or subtotal thyroidectomy, and use of antithyroid drugs are superior methods to use of radioactive iodine. Radioactive iodine is also known to be a risk factor for onset of thyroid eye disease for patients who have a pre-existing thyroid anomaly. Iatrogenic hypothyroidism, that usually occurs when patients are treated with radioactive iodine. Patients who were initially hyperthyroid and treated with radioactive iodine tend to develop iatrogenic hypothyroidism. So it's very important for patients who are on radioactive iodine to be monitored very closely to ensure that they are not tipped into iatrogenic hypothyroidism, which will worsen or increase the risk of development of thyroid eye disease if they did not already have it. Then also the assay of thyroid TRAB, as we mentioned earlier, when we talked about the thyroid stimulating hormone receptor antibodies, its presence of those antibodies confirm the presence of the disease, and also an assay of it, seeing that you have high levels of this also is a negative prognostic value for presence for development of eye complications and loss of vision. So we restore thyroidism, monitor thyroid function test, 6 weekly. We use of antithyroid drugs and surgery, as I mentioned earlier. Now, as I mentioned earlier, the use of radioactive iodine is heightened with orbitopathy risk. And for patients who have to be on radioactive iodine, the use of low-dose steroids is important to reduce the risk of iatrogenic hypothyroidism. This is where a very close synergism with the ophthalmologist, the physician, the nuclear physician is office in dry eye disease, in thyroid eye disease has been found to take increasingly serious consideration. And it's thought that there's an entity known as occult thyroid eye disease, whereby actually ocular surface dysfunction would actually be an early manifestation of thyroid eye disease. And many times patients will come in and they are misdiagnosed. And it's thought that the symptoms are not attributable to, to the usual mechanisms with thyroid eye disease. Is thought to be attributable to inflammation with and the absence of lid the covering, as you will see in lid retraction and proptosis, where you have increased ocular surface, is something that has been noted here. And these patients respond to topical anti-inflammatory agents. At this point in time, other features that are suggestive, and highly common with thyroid eye disease may not be present. So this is one patient that could actually slip through the cracks if one is not especially careful. Other local treatments, take advantage of the fact that the ocular surface features will increase in severity as the disease progresses. So it's found that about 65% of patients who have thyroid eye disease actually have dry eye disease, and with a female preponderance. And it could actually be described as subjective dry eye disease or objective dry eye disease, where you could actually have the patient symptomatic, or you could actually have it on laboratory testing with changes. We found that there are changes in the lacrimal gland, there are changes in the conjunctival histology tissue, there's changes in the tear ocular surface, and these are actually objective findings that could be seen in patients who may not necessarily have these symptoms. The severity of the dry eye and the severity and the activity of the thyroid eye disease have been found not to have a direct correlation. It's also been found that there's a meibomian gland dysfunction present in these patients, and the dry eye disease can affect any type of thyroid eye disease patients, the young, the male sex, the female sex, irrespective of age or gender, and irrespective of severity or activity of the patient. Local treatments that are advantageous for this include the use of ocular lubricants, as we're well aware, artificial tears, also advisable to elevate the head of the bed, and to use of nocte ointment. So this is looking at treatment for mild disease. And we talked about, if I would just remind us of what are the criteria for mild: proptosis less than 3 mm above normal, lid retraction less than 2 mm, and transient or no diplopia. So general measures, as we talked about: correct thyroid eye disease, correct thyroid anomaly, stop smoking, and if these risk factors are present, these risk factors, as we mentioned earlier, the patient has high TRAb levels, the patient is on, for one reason or the other, is on radioactive iodine. Okay, those are risk factors, and there's still thyroid dysfunction. The patient is still not euthyroid. That means there's an increased risk. So proper referral for specialist care is advocated, and of course you want to search for dry eye disease. So as we mentioned, local or systemic treatment, tears, gels for cornea protection, and the use of selenium per oral 100 microgram PD for 6 months has been indicated now for mild disease, and it's been thought that this is able to stabilize the patient and reduce the risk of progression, reduce the activity of the disease, and reduce risk of progression from mild to moderate to severe. And if quality of life has been impaired, as I mentioned earlier from the assessment, there's a case being made for low-dose immunomodulative treatment to be commenced on these patients who have mild disease. The quality of life, it's been found that with selenium treatments, it improves quality of life, it reduces progression of the disease, it reduces clinical activity score, and the benefits for using selenium are sustained after 6 months. And the good news is that it is locally available. So whatever moderate to severe disease, once again, let's look at what are the parameters, what are the things that make moderate to severe. So we see the intermittent or constant diplopia, lid retraction more than 2 mm, exophthalmos more than 3 mm. Okay. So remember, we said the house is on fire. Before you build it, you have to put out the fire. So if the patient has moderate to severe, you want to find out, is the disease active or is this inactive? So patients who have active disease, these patients are an indication to commence immunomodulative therapy, and a lot of immunosuppressive therapies have been used, but studies and observations have given this as a first-line treatment. Use of intravenous prednisolone, 0.5 grams per week for 6 weeks. Initially, it was given as a monotherapy, but it's been found over the past 2 years that the addition with mycophenolate, which is another oral steroid-sparing immunosuppressive agent, which is given orally at a dose of 0.72 grams per day for 6 weeks, gives an additive effect and reduces the clinical activity score, reduces inflammation, and then for patients. So if patients are placed on this, so what do? You watch out for the patient, you watch his response. These drugs normally will give a response within a few weeks. So if patient has a response, and the group of patients with a response and the one without a response separated into 2 groups. So patient has a response, which might be a good or just a partial response. The medication is continued for the next 6 weeks at the dose of 0.25 milligram. And this is continued till the disease is inactive. Now, what are the endpoints you are looking at for treatment to be able to assess this? You are looking at extraocular motility, you are looking at exophthalmos, and you are looking at diplopia. In addition, also other soft tissue effects, chemosis, and injection. So if there's no response, am I audible?
Yes, please.
Yes.
If there's no response to the use of IVMP and mycophenolates, so a second line of treatment is now instituted for this mild to moderate disease, and given till the disease is inactive. So what are we talking about? Second line of treatment. The first line of treatment is the use of intravenous steroids, like I showed here, and the total cumulative dose from this 0.5 milligram IV for 6 weeks, and thereafter continued by 0.25 milligram, gives a total cumulative dose of 4.5 gram. And normally the response to this first line therapy shows within 1 to 2 weeks. So the use of IV steroids. These are the first line of treatment. You want to place a patient on IV steroids, you want to do tests at the onset. So because you want to find out not every patient will benefit from it, and not every patient will have an advantageous effect from it. So you want to sort that out. So certain tests you might have to do at the beginning of treatment, liver function test, liver ultrasound scan. You want to check for hepatitis viral markers and autoantibodies. And you also want, during the treatment, you also want to monitor the liver function test, liver enzymes, and the blood glucose and the blood pressure. And at the completion of treatment, you want to assess adrenal function. Remember your hypothalamic pituitary axis, giving intravenous steroids and reduction of and suppression of adrenal function. So contraindications to use of IV steroids. So a patient who has had recent hepatitis, the patient who has liver dysfunction, remember you are assessing your liver enzymes, patient who has severe cardiovascular morbidity or severe hypertension. So such a patient who has contraindication to steroid use, also a patient who responded to steroid use, as we see here, a patient for whom you commence steroid use and there was no response. Such a patient will benefit from second line treatment, and then these are the second line treatments. These are all immunomodulatory treatments. They include cyclosporine, azathioprine, teprotumumab, rituximab, and tocilizumab. These are all different immunosuppressive agents acting with different mechanisms. Just important to note that for any patient who is on radiotherapy, radiotherapy with is found to be synergistic with either oral or IV glucocorticosteroids, and a contraindication, however, to use of radiotherapy as a second line treatment is diabetic retinopathy, uncontrolled hypertension, and any patient who is less than 35 years old. And it's important to know that for a patient who will benefit from radiotherapy and synergistic with oral corticosteroids as well, such a patient, usually we talk about if he needs follow-up surgery, we'll still be able to do surgery. And the good advantage is that even when the patient has orbital radiotherapy, at active disease, the patient will still be able to have a follow-up surgery for reconstruction later on after the treatment. Other drugs include the oral cyclosporine, and then I will brief word about teprotumumab. Is the latest baby, one of the latest baby for treatment of thyroid eye disease. However, it's only available in the US. It has a different mechanism of action. One of the autoantigens that we talk about in the causation and the pathogenesis of thyroid eye disease is the insulin growth factor receptor antigen, which actually has similarity with the TRAB that we talked about. And this drug is directed against that autoantigen. And for now, it's only available in the United States. Rituximab and tocilizumab are also immunosuppressive agents that are used as second-line agents. And it's been found that several of these drugs tend to be synergistic with an additive with oral glucocorticosteroids. So like I mentioned before, what are the endpoints of the medical treatment? You're looking at the proptosis, you're looking at ocular motility and diplopia, you're looking at remission of activity, injection, edema, chemosis, and several of these immunomodulatory agents have different responses, give different responses to these endpoints. For example, teprotumumab is very responsive, treatment on it gives a lot of response from proptosis, and cyclosporine as well, and tocilizumab. There's also marked reduction of proptosis. Ocular motility and diplopia, they also respond well to radiotherapy, they respond to cyclosporine, and they respond to teprotumumab. Remission of activity, there's responsive, its response to teprotumumab, tolicizumab, and the intravenous steroids, IV methylprednisolone, that is commonly used as the first line of treatment. So this is just a schema for the biologicals: myclophenolate, rituximab, azathioprine, tocilizumab, cyclosporine, and teprotumumab. They all have different mechanism of action. Now, it's important to know that, like we mentioned earlier, the fibroblasts are the end effector organs for the autoimmune reactions and the responses that you see in the orbit. And several of these mechanisms are finally elicited by activation of B cell and T cell, and use secretion of chemoattractants, cytokines, interleukins and the like, which many of these biologicals actually act against. So that's their general mechanism of their action. So what do we do for sight-threatening thyroid eye disease? So we mentioned what are the parameters that make sight-threatening graves of orbitopathy or thyroid eye disease. We talked about optic neuropathy, corneal breakdown from exposure. Am I still audible?
Yes, ma'am.
Yes.
Globe subluxation, thank you very much. And several forms of severe forms of frozen eye, choroidal folds, and postural visual obscurations. So when you have sight-threatening thyroid eye disease, this is an emergency. It is an emergency, as the word says, it's sight-threatening, and the treatment, of course, you're talking about, you have to continue your protective mechanism, your supportive treatment that you have been doing. And you want to, right now, what is at stake? Visual loss either from the optic nerve or from the cornea. So at this point, you protect the cornea by all means with aggressive topical lubrication. Every means possible for which you can protect the cornea is called into play. The use of tasography, the use of glue, the use of antibiotic, the use of keratoplasty, and even urgent lead lengthening techniques to at least reduce exposure of the cornea are all indicated in these patients. And of course, you want to commence immediate intravenous methylprednisolone at there are several regimens, but the common one is to use 0.5 to 1 gram as a single dose. daily ophthalmic monitoring, and you expect to see a good response at a week. Once the patient has a good response, you continue the dose of IVMP till you have a total dose of about 8 grams per cycle. You know, if there is no response or there's deterioration after a week, may I go on?
Yes, please.
Yes, ma'am. Please
If
go
there is no
ahead.
if there is no response or deterioration after the use of IVMP for a week, you have to do an urgent orbital decompression. Okay, so we said we put out the fire. Now all this, we're talking about a disease that is active. Well, we want to put out the fire, and we put out the fire. Remember, we are at Arundel's curve, and we have come down from the inflammation. So what do we need to do to rebuild? Surgery. Surgery for the later stage of reconstruction of thyroid eye disease. I'm seeing a sign here that says my internet is unstable. Can you hear me well, please?
Yes, we can hear you.
Okay.
Yes,
Well, I
My
can hear you.
internet just told me it's unstable. Okay, so surgery is sequential, you know, and it's only indicated apart, of course, from when, just as what we've talked about now in this thyroid optic neuropathy, where you come in as an emergency and a sight threat, and the patient does not respond after a week of IVMP, that's when you have to have urgent decompression, even if the disease is active. Otherwise, surgery is only done when the disease is inactive for about 6 months and is done as part of the treatment for this thyroid optic neuropathy, as I mentioned earlier, only in an active condition. So this surgery is sequential. Why? Because if you interfere with the orbit, you are going to affect the orientation of the extraocular muscle. So doing orbital surgery gives you tendency to have imbalance of the extraocular muscle. So you are going to have development of squint, which you will have to take care of. And doing surgery on the extraocular muscles affects the position of the eyelids. Therefore, you need to do your eyelid surgery after your extraocular muscle surgery. So to that sequence is adhered to and maintained. So okay, we had mentioned this, we just talked about this, the indications for surgery when we talked about sight-threatening thyroid eye disease, when there's compression, and then, okay. So in decompression, so what are you doing actually? You are expanding the orbital space to create a space. Remember, we talked about the fact that the extraocular muscles are enlarged, they are big, there's fat, a lot of fat, and tissues have imbibed hyaluronic acid and water and the like. So what we do in decompression is that you just expand the orbit and create a space for the enlarged extraocular muscles and soft tissues. So we're expanding it so that all these other things can further sink into the orbit, reduce then reduce at the end of the day the cosmetic blemish we have, and also reduce the pressure we have on the ocular nerve. So you have two forms of decompression. You have the bone removal orbital decompression, or you have the fat removal orbital decompression. And the bone removal can be either an isolated lateral wall, or what you call the balance, that's a medial and lateral wall, or a 3-wall. And it's important to note that you're able to achieve good about 2 to 3 mm of reduction in proptosis, of movement of the globe into the cavities, per wall. So you have expansion either into the maxillary sinus, into the lateral wall of the orbit. You can have the fat removal orbital decompression, which can be done alone or associated with bony decompression. And then it said that if you remove as much as 6 cc of fat, you can actually achieve reduction of 3 mm of proptosis. So this just to highlight what we are talking about. So here we had this, can appreciate this enlarged muscle. Now this might not be able to show also how much fat is also here, but this enlarged muscle, and there's a medial decompression that has taken place here. You can appreciate this here. You can almost not see a medial orbital wall here. So you can see a lot of the muscle has sunk into this towards the ethmoids, okay? So this patient has had a medial decompression. So you can even appreciate, look at the extent of the proptosis. This is what you can do. Now, if you look at, this is the zygoma. So that's what you call, the radiologist call the interzygomatic line. This is from here. Look at it, try and measure this line here. The orbit, the globe is not supposed to stay above, the posterior extent of the globe is not supposed to be above this interzygomatic line. You know, by the time you are seeing the posterior extent of the sclera above the interzygomatic line, that tells you that there's marked proptosis. That's how the radiologists are able to assess proptosis. So now let's look at here. Look at the posterior extent of the globe and look at this zygoma here. Yes, the zygomatic line. Look at how much you just had imagined that there's a lot of proptosis. Now compared to here, look at the anterior aspect, and now look. So that tells you the globe has sunk in, and we're not surprised because he has had a decompression here. Can you appreciate that?
Yes, ma'am.
Yes, we can.
Okay. I think yes. My pictures here are, oh sorry. Okay, I think I can only vaguely appreciate this. Okay, so lateral wall decompression is thought to be reliable and gives a predictive compressive effect, and it can be done even without I forgot to mention that you can do decompression surgery either from an external approach or from with an endoscopic approach. And with the lateral wall, you actually risk new diplopia, which is actually a risk for every form of the decompression anyway. And it's thought that when you do that, you also have a shift of the lateral rectus muscle. As I mentioned, you tend to have shift and associated secondary diplopia from a shift of the extraocular muscles when you do the compressive surgery. Another complication that might arise is anesthesia in the temporal region and the CSF lead, and of course a change in the interpupillary distance of the patient post-operatively. With fat decompression, it's thought that you can have better outcomes. However, the patients who will benefit from fat decompression are those who we have their proptosis from a lot of fat in the orbit. So you can actually have the fats being selectively decompressed, unlike when you have most of the proptosis and most of the orbital congestion being from thickened muscle mass. And remember, I mentioned earlier that with an MRI, you're able to actually separate, the extent of fibrosis and the extent of inflammation, which is not as easy to do from a clinical assessment. And so the MRI in preparing for a fat decompression is called for and highly indicated. So what are the other interventions that we might do for the extraocular muscles? The extraocular muscles restriction could occur either from the disease, as you have restrictive activity, or after decompression, as I've just mentioned. So, and then just for the residents, there's a mnemonic that the radiologists use to determine the extraocular muscle that are involved in the restriction in thyroid eye disease. Is called slow. The muscle that is most commonly involved is the inferior rectus, then the medial rectus, then the superior rectus, the lateral, and finally the obliques. So it's called slow. Okay, so the extraocular muscle restrictions usually are the inferior, commonly the inferior rectus and the medial rectus. So they give rise to a hypotropia and an esotropia at rest. And like I mentioned, the strabismus can be from the disease or after the compression. So in a patient who has strabismus from decompression or even from the disease, as much as possible, good patient counseling is very important pre-operatively, and you have to let the patient know that you might not be able to achieve binocular single vision in every position of gaze. So the patient counseling is so vital. Your goal is to ensure that the patient has BSV in the primary position and in the reading position. So this is where our strabismus surgery comes into play. Okay, what about the lead interventions? Okay, the lead interventions may be for the upper lid or the lower lid, of course, after decompressive surgery and after extraocular muscle surgery. However, interventions can also occur at the active stage. We'll come to that. You can actually do some lead interventions at the active stage of the disease, but usually they are the inactive stage of the disease. So what are the things you can do at the active stage of the disease? So we have either botulinum toxin for lead retraction, the use of fillers, the use of triamcinolone injection into the levator muscle. And at the inactive stage, you actually have either mulerectomy or levator recession. So at the active stage of disease, now these are, like I mentioned, they are interventions, not surgeries, so per se. So the use of Botox, so the patient has severe marked lead retraction, but the you might not want to do that at the active, you might not want to wait for the disease to be declared inactive because of the effect on the quality of life of the patient and all the other things. So at the active stage, these are what you can do. Injection of Botox into the levator muscle, and it just has a duration of response for about 6 to 12 weeks. And Botox injection is irreversible. It's actually found to be more active in inactive, more effective in an inactive stage. However, can be used at the active stage of the disease. And one must be very careful, because you can actually have ptosis as a side effect and diplopia if the injection extravasates or moves into the orbicularis muscle or into any of the extraocular muscles. So the use of intralevator triamcinolone is more effective in active thyroid eye disease, and when you have upper lid retraction, and of course by virtue of its anti-inflammatory effect on the levator muscles at a dose of about from 10 to 40 milligrams titrated for the patient, and it's thought to have a duration of 2 to 4 weeks, and like I said, more effective in active. It is not reversible. However, there's a drawback because of the side effect of steroid-induced glaucoma that may occur in these patients. The use of hyaluronic acid, this is still in active condition, active phase of the disease. It can be used in upper lid and lower lid retraction at a dose of 0.4 to 5 mil. It's said to lengthen the lower lid retractor and the levator muscle, and the effectivity is up to about 6 to 12 months duration. It's more effective in active disease, and this is reversible with, of course, hyaluronidase. So now we see what we have back to our Rundle's curve. We said our aim for the Rundle's curve is to try to shorten and to flatten it. So now we talked about the active phase and the static phase, inflammation here and fibrosis here. This activity and then fibrosis, sorry. And remember, we said activity, talked about clinical activity score, inflammation, while this fibrosis and the right talked about outcome, effectivity, quality of life and effect on quality of life and the severity. So if this is our activity, so immunosuppressive therapy helps to flatten our curve here. Immunosuppressive therapy, as I mentioned earlier, intravenous methylprednisolone and the other biologicals that I mentioned, and the use of rehabilitative surgery. So while we flatten the curve, we also shorten it. So just to show and get better outcomes. So rehabilitative surgery helps to flatten this plateau aspect of the curve and brings it further down to baseline as much as possible. So other aspects of thyroid eye disease. Let's look at pediatric thyroid eye disease. Do you have thyroid eye disease in pediatric patients? Yes. However, they tend to have they tend to run a slightly different course. It's found that they actually have no fibrotic phase generally. They tend to resolve. They are less common, of course. The cause is more benign. There's less ophthalmopathy. Like I mentioned, no fibrotic phase. And the thyroid eye diseases usually regresses after euthyroid status is assured, is restored, which is different from what you have in adults, where even with a euthyroid state, the disease will still run its course and then continue. So the use of local treatment and with watchful waiting. Now, the use of intravenous methylprednisolone is highly with a lot of care and consideration. These are children growing, and we know what the use of high-dose steroids can do to them. So it's only given under care and watch. And of course, we talk about our multidisciplinary therapy, where we're bringing in our pediatricians, and our pediatric specialists, as the case may be. And of course, radioactive iodine is an absolute no-no. It's contraindicated for children. So COVID-19 and thyroid eye disease. COVID-19 has entered into our medical lexicon to stay. So it's thought that infective agents, they precipitate or they exacerbate autoimmunity. How? By activation of the immune response. And it's thought that with COVID, there had been direct or indirect rules. And actually, the direct rule is just as we mentioned, it's a dysregulation of the immune system and release of cytokines to perpetuate the inflammation that had already, was already ongoing for the disease. It's also thought that other indirect effects, which came in the light of the COVID, inability to get consults, inability with travel restrictions, and people had discontinuation of drug therapy and their regimens were discontinued and all that, interruptions and all that. So it's been found that sight-threatening cases of thyroid eye disease actually did rise, and the risk and the threat of sight loss became higher, during this time. I don't think I have the slide on thyroid eye disease and pregnancy, but suffice it to know that we can also have the management of thyroid eye disease in pregnancy, and it's thought that, the use of, depending on the clinical activity, as we mentioned earlier, the use of steroids, is highly taken with a lot of consideration and care, under the guidance of the obstetric specialists, but there's still a role for treatment for steroids in patients with thyroid eye disease in pregnancy. Of course, the use of radioactive iodine is an absolute no-no for such patients. And of course, continuation of local therapies, as we would for any other patients, is absolutely encouraged. So what are we talking about now? New treatments coming along the way and all that. So the biologicals, the biologicals are gaining more ground, and the use of immunoglobulins, had been advocated. However, currently they are not so favored because they are very expensive, and there's a risk of infection actually do limit their use right now. And of course, they need to be given by IV, routes. So that also limits their the development of immunoglobulins right now. The use of thyroid stimulating hormone receptor antagonists are being developed now, and that's another area of interest. Belimumab is a monoclonal antibody against B cell activating factor. It's using part of the mechanism that rituximab and mycophenolates are using, is being developed. Microbiome manipulation, this just refers to using organisms which are already existing and present, and taking advantage of their genetic makeup to fight, as it were, the autoimmune attack that we have in a thyroid eye disease. So this is another area for consideration. Another, inhibition of fibrosis. Rapamycin is being developed now as we're talking about immunomodulatory therapy for active disease, and we're talking about building, surgery, and all that at the secondary stage. Supposing we have medication that we can use that actually deals with the fibrosis and reduces the effect we see at the chronic stage of the disease, and that's the role that rapamycin is going into, and is being subject to extensive tests and reviews and RTCs right now. Another thing in the future is precise endoscopic navigation guided minimally invasive 3-wall decompression, and of course robotic bony decompression. Other treatments that are being talked about now are the use of other forms of antioxidant treatments. You know, since we have talked about the fact that alteration of a redox state is important, you know, in the development of the pathogenesis of thyroid eye disease, use of statins, because it's been found that when there's an alteration in the imbalance of cholesterol status, that it worsens the outcome for thyroid eye disease patients. So perhaps, you know, but there have been a lot of equivocal reports, you know, on the use of statins and beneficial effects. And of course, vitamin D, you know, it's also been investigated. And also there's a lot of work going on. There's a lot of interest, you know, and new forms of therapies taking cognizance of the different mechanisms and pathogenetic mechanisms in the clinical picture of this disease. So what would be the ideal intervention, ideal drug? You know, it will be a drug which will be beneficial, be able to take care of our inflammation, be able to take care of our fibrosis. It will have few side effects, and it will be cost effective. You know, and by the grace of God, we will get there. Thank you very much.
Thank you so much, Ma, for the very extensive and detailed presentation. And I'm sure everyone has learned one or two things. And for those people that are here, they are better informed about thyroid eye disease. So thank you once again, Ma, for the very brilliant presentation. So without further ado, I would go straight to the questions. I have a couple of questions here. I'll just read them. Apologies, network has been quite unstable for me. So some of them I'm not seeing on chat box, but I have some of them here. So the first question, Ma, is that what is the impact of secondhand smoking on thyroid eye disease?
Okay. Thank you. Thank you. You know,
yes, what is it? Okay. Did you get me, Ma?
Yes, yes.
Okay.
Yeah, it's, you know, I like the way the pediatricians talk about this. I like the way they handle it when they talk about the risk of smoking for children, and when they advise our children who are, you know, residents in homes where you have adult smoking, you know, and they talk about they still have how will I put it now? The effects of the smoke on the lungs still is problematic for people who are exposed to that, especially children whose parents are smokers. By that same mechanism, you know, it's thought that why is smoking dangerous, you know, in the etiology of thyroid eye disease. Cigarette smoke has been associated with increased risk and severity of thyroid eye disease, even at the second-hand level. For the primary smokers, the effect of smoke within the paranasal sinuses, the airways, and all that have all been well documented. And it's been thought that, you know, there's resultant increase in cytokine production, increase in a lot of chemical products that have been found to be perpetuating of orbital inflammation, release of cytokines, and the rest. Now, even for the primary smokers and as well for the secondary. Now, what we now want to say is that to what extent do we put the secondary? Are we talking about the secondary who lives in the same house, exposed to the same close environment as the person, or somebody who I work with you, or how close is the proximity? But I'm using the extension of the argument of the pediatricians, you understand? And by that same token, I I would say it is not safe. To what extent we will be able to have that for thyroid eye disease, I do not have values for that. But using the extension of the arguments of pediatricians, you know, of children exposed, living in homes where you have primary smokers and still being at that risk, I will still extend that risk for thyroid eye disease for a patient who is an occupant of the same home as a smoker to still be, you may not have as high as risk as a primary smoker, but definitely you will not be at baseline level. I hope I'm clear with that. Okay, you know, so, and it's smoking is so much a high risk factor, you know, because it enhances cytokine production, it increases adipocyte production, it increases fibroblastic effects, you understand? And as soon as smoking is stopped, the effects, the risk for development of eye manifestations for patients who have thyroid anomalies is reduced. And even for patients who already have eye manifestations, who have thyroid eye disease, the risk of blindness, the risk for them is also many-fold reduced. So reduction of smoking is a very, very important risk factor. And with that, you know, I would also extend that to anybody who is a recipient of secondary smoke. You know, I don't have the values as well, but I'm using that pre-existing knowledge to extrapolate to that knowledge, you know, and I don't know whether I'm communicating with somebody.
Yes, thank you so much, Ma. Thank you. So this other question, or the next question, is that selenium supplementation was used in European population who generally have a low level of selenium.
Yes.
Translatable to our population?
Thank you very much. Yes, that's true. That's true. And it's actually been advised that, you know, in climes and geographical locations in which it has been proven that there's adequate selenium level, you know, you may not need to have selenium supplementation. Now, we don't have the studies yet. You know, a lot of work is still ongoing. We don't have the studies yet to show what level of selenium status that we have here. However, the beneficial effects have been found to be so much, you know, and even in climes in which selenium is used, in a lot of places in Europe, United Kingdom, in fact, it's for every patient who comes in, you know, with mild thyroid eye disease, selenium is given, you know, the effects have been found to be so much. And even when it is stopped, the sustained effects have been so beneficial that it's almost now a norm to advise that, you know, a lot of our multivitamin supplements actually do have some little level of selenium, but now the thinking is perhaps we should go and see how much selenium, you know, we actually have at baseline level. And that still calls for other studies here, but I don't think there's much to lose for us to consider it as part of what we might have to put into our treatment armamentarium. Am I still?
Okay, thank you. Yes, we can hear you. Can you hear me? So
the selenium, okay.
The other question is there any role for vitamin D in the treatment of mild thyroid eye disease?
Vitamin B.
Vitamin D.
Vitamin D, okay. It's a lot of reports I've gone through. I've still a lot of inconclusive reports concerning vitamin D. However, it's been found that in patients who have low vitamin D stores, they tend to have faster recurrence of thyroid eye disease after resolution, you know, and tend to have even after restoration of thyroid function, they tend to have a higher rate of recurrence. However, you know, there's still a lot of inconclusive reports and extrapolations. So vitamin D has not found its footing yet as a formal treatment, you know, but it's nice to know that it's still being considered. There's thyroid eye disease and its treatments, in all honesty, from what we can see, there's still a room for a lot of research, a lot of treatment trials and all that, you know, but these are areas that are still being looked into. However, vitamin D on its own has not yet been stated as a formal treatment for any form yet of thyroid disease. Still, the way we're talking about the roles of statins, the role of cholesterol still being considered, but vitamin D, not as, the role is still not as strong as, excuse me, what we have for selenium, for example.
Okay, thank you, ma'am. Someone would like to know that what's the accessibility to pharmaceutical and non-pharmaceutical options for this treatment? How accessible are these, you know, treatment modalities?
Thank you very much. Yeah, yes. Ocular lubricants, yes. Artificial tears, yes, available. Elevating the head of bed, available. I think pillows are still sold in the market. You know, it's available. Control of the risk factors we talked about. Stopping smoking, available, yes. Anti-thyroid drugs, available. General surgeons to do thyroidectomy, available, yes. Okay, now let's talk about active disease. Okay. Intravenous methylprednisolone, available, yes, very available. At least I've given patients severally, okay, available. Now we'll talk about the biologicals, okay. Cyclosporine, available. Microphenolates, yes, not so much, yeah. Teprotumumab, not available, only in the US. Tocilizumab, no. Let me, okay, excuse me. Okay, I think I went out of my presentation. Okay. Okay. The biologicals, only some of them available. Selenium, yes, available. Yeah. There's a local preparation that is actually 200 microgram. Yes, available. The surgical therapies. Okay, let's look at orbital decompressions. We have a few orbital surgeons in the country here who do decompression. Some of them even do endoscopic decompression. Yes, available. Bony decompression. Yes, available. Strabismus surgery. We have the skill. Yes, available. Eyelid interventions. We talked about Botox. Botox, yes, available. And triamcinolone, yes, available. Hyaluronic acid. I'm not too certain about that. Eyelid surgeries, blepharospasty, available. Control of cornea, glue, therapeutic glues, bandage contact lenses, available, yes. Keratoplasty in 1 or 2 places here, available. Am I still audible?
Yes, very well.
So have I answered that question? How available are these modalities? I think a lot of them are. Yes, not all, but a lot of them are. Yes.
Okay, thank you, ma'am. So the other thing is that someone wants to know about the national experience in the management of thyroid eye disease.
Okay.
Maybe a study, national study, or something that has been done, you know, for the prevalence of thyroid eye disease.
In fact, thank you for that question. And I don't know whether Dr. Bola, esteemed Dr. Bola Balogun is still in the house.
Yes, I'm here.
Can I please make a request for you to allow her to, she has had a lot of experience on this, and I really wanted her to put in 1 or 2 words. If it's okay by you, moderator, please.
Definitely.
Yes, please, Dr. Baloguma, the floor is yours.
Thank you, Dr. Alen, for the invitation. Presently, we are actually trying to collect data in last week. We're looking at the clinical features, symptoms, signs, everything that the patient presents with. And we're also collecting data on using the UGOGO form. These forms help us to look at the clinical activity. It also assesses the psychosocial part of effect of thyroid eye disease. And I'm already talking to one or two of us if we can extend the study nationwide. And I would like to say here really, Dr. Allen, that you are one of the people I'm going to talk to. I already spoke to Dr. Edak. Maybe she hinted you. Thank you very much. So we are working on something.
Yes.
Okay. Thank you so much, ma'am.
Thank you. Thank you. And actually, I would like to, the Ugogo form is it's actually self-explanatory. If you go to the Ugogo site, you actually have two forms, the form for the initial presentation and the form for the follow-up, and when the patient just comes just to tick, and it makes your collation, it makes your assessment, your clinical assessment, and it's I would advise the residents, if it's possible, because it helps you to check for things that on your own you might not have remembered, you understand, to check for, and all these findings that we talk about are there, So thank you very much, Dr. Baloguma. Thank you.
Okay, thank you very much, ma'am. So someone wants to know how is IV methylprednisolone given? It was mentioned, but maybe the person didn't catch that. So please, could you kindly go about it again, ma'am?
Okay, that's for which part of the let's look now, which stage? Okay, let's look at moderate to severe. That's when you give it. Okay. Okay. Where's my slideshow? Okay. 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 I'm able to okay, moderate to severe. So 0. Is this what you wanted?
Well, I'm not quite sure, but I think this will do.
Okay.
Yes.
This is for first of all, we need to know what we mean by moderate to severe active. Okay. So the parameters, for moderate to severe, so that we make it, okay. So these are the parameters. The patient has these parameters and the disease is active. What do we say by active? That means clinical activity score 3/7 and above at the first visit, or 4/10 and above and this is our parameters for clinical activity score. Okay, so when the patient comes, for every thyroid patient, you want to know where you are at. This just makes your work easier at determining the clinical activity score. If the patient is less than 3, many patients that come like this are actually less than 3. Patient comes, that you're not going to give any immunosuppressive therapy. You understand? Patient comes like this, and you want to assess, is he mild, moderate, or severe? So you know where he is at, in your curve, and what treatment you are going to give him. So you 0.5 grams of IV methylprednisolone per week, once a week, for 6 weeks. Either it is given alone, but now with the recent Ugogo classification, using Ugogo treatment modalities for 2021, the use of mycophenolate was found to have been synergistic to it, so given with that, and watch after a week and look at the response. If the patient has a response, but the response is partial or good at all, then you continue for 0.25 milligram, for another 6 weeks. So that means a total of 12 weeks you have given him, okay? And then you continue that, till the end of treatment, using the follow-up investigations and all that we had talked about earlier. And of course, if there is no response or there's any deterioration, that's when we go for the second line treatment. So this is the methylprednisolone. So another time you give IVMPs when you have sight-threatening thyroid eye disease. And this is, like I mentioned, an emergency. So just as is indicated here, you give IVMP 0.5 to 1 gram as a single dose. Many times we give it actually, just the same way we, when we want to give patients that have come with acute optic neuritis, we have to give it, maybe in the infusion, because you want to make the patient stay on bed, monitor BP and all that, give it as a consecutive or alternate day dose for 3 doses. Actually, some people give it as a consecutive dose, but it's advised to give it as an alternate day dose for this, because the side effects are a lot less. So you can monitor it after a week, and then if there is a response, you continue your immunosuppressive therapy for another 0.5 IVMP every week till you have a total dose of 8 grams. But if there's no response, immediately you take the patient and send him for an orbital decompression. Okay, have I answered that question?
Yes, definitely, ma.
Okay.
So you mentioned that patient needs to be euthyroid before instituting the medical care for thyroid eye disease. This person would like to know if this is an absolute requirement, because some randomized clinical that a patient needs to be euthyroid before instituting the medications.
Oh, no, you are running, you are running them pari passu.
So the person would want to,
let's get it right. You are running them pari passu.
okay.
Not that the patient comes, or when you are tired, this patient comes in with, I'm looking at, for example, let's look at this, moderate to severe. On the left side of the screen, you have refer specialist, okay? Correct thyroid dysfunction, smoking, avoid hypothyroidism. Do you understand? At the same time, you are giving your immunosuppressive therapy. Do you understand? At the same time, you are taking care of his cornea. So you are running it pari passu. Are you getting me? So you are instituting local therapy. You are taking care of risk factors. You are dealing with the cornea. You are correcting thyroid dysfunction. Knowing fully well that if you keep the thyroid, if you keep the patient either hypo or hyperthyroid, you are risking further ocular complications. So you are ensuring the patient is being managed. This is the multidisciplinary therapy we are talking about. So the patient is getting his anti-thyroid drugs and all that. Is that clear now? Is that clear?
Yes, now? Definitely. Yeah. Okay. So that answers the question. So someone would like to know about molerectomy surgery for lid retraction, okay, because it's usually indicated for blepharotosis. So somebody would know.
Yes, it's actually done when the disease is inactive. It's one of the interventions done. I didn't have it in it. I just listed it. Okay, it's because what causes the lid retraction in the first place is the fact that the excessive action of catecholamines strictly on the Mueller's muscle. It seems like a paradox, so to speak, but it's thought that with intervention to the Mueller's muscle, we're able to take care of the thing that is getting the effect of the thyroid, the circulating catecholamines. Actually, levator recession is thought to be a superior procedure to that, because you can actually appreciate that you are going to lengthen the lid itself and take care of the apparent shortening that you have from a lid retraction. Okay, I have not had to do a muellerectomy. I must be honest, I've not had to do a muellerectomy. I've actually more comfortable with dealing with operating on the levator muscle. So I think that's the principle there. That seems like a paradox, because that's what is being acted upon by the circulating catecholamines. So remove the target action, remove the target organ, which is the Mueller's muscle.
Okay, thank you, ma'am. So why is radioactive iodine contraindicated in children?
Because it is thought to increase the risk of secondary tumors, just like radiotherapy. Okay. So, and the children are still growing, you know, a lot of very hyper proliferative tissues in the children. So it's thought to deal, you want to deal with their thyroid anomaly, thyroid imbalance by some other method. So.
Okay. So how do we treat thyroid eye disease in pregnancy?
If I may come in, you see,
Okay.
a lot of these patients, you know, we must take cognizance of the multidisciplinary therapy. We must change our understanding, our mindset of it, you know. And a lot of these issues, the pediatricians and children with thyroid eye disease, the pregnant women, you are not going to be the sole specialist handling them, you understand? But remember that when they come in with their eye complaints, all their primary specialists will come back to us. Are you following me? You know, but at the end of the day, you know,
Yes.
you might not be the person who has to institute the specific therapy, but you will have to be the one who will give you might have to be the one leading the course, because, oh yes, they can see the way the eye is looking. But I will have to tell the pediatrician, look, let me give a simple example. I had a child who had traumatic optic neuropathy, and I needed to give the person IVMP, you know, and I had to tell the pediatrician, I need to give this child steroid. She was about 2.5 years old. I need that, you know, the child was in fasting blood sugar, do and you do and this and do all that. But the point was, I was the person who saw the need to give intravenous steroids, you understand? And they give me their guide. They are afraid of adrenal suppression. They are afraid of those other things. So, you know, so we work in tandem with them, and we must be very keep this in the forefront, and we're very, very conscious of this when we talk about the patient-centered care, taking advantage of the multidisciplinary specialist care that is available with us, so that at the end of the day, you are not the repository of all knowledge. If I'm going to see a pregnant woman with a thyroid eye disease, of course, I have to explain to the physician, to the obstetrician, you know, I look at the patient. First of all, you have to establish what is the risk of blindness in this patient. So that's where you have your knowledge of your risk factors. What are the risk factors existing in this patient? Is the thyroid status normal? If the thyroid status is not normal, we have to ensure it's normal, because you are risking blindness, you are risking thyroid eye disease, and you are risking more complications when the thyroid status is not okay. What are the other risk factors? In this climate, you might not have smoking, but that is one risk factor. What else? Can you assess the thyroid and the TRAB antibodies? If you can, find more higher levels of that, increased risk of sight loss, you know, as the ocular features develop. So these are the things you can now use to put a case across. Is the disease active? Is the disease not active? If the disease is active, oh yes, I have to now give immunosuppression. Now I'm talking with my obstetrician. Now I have to give a pregnant woman this. Now we're talking about at what trimester of the pregnancy. So I think at the end of the day, the books might talk about this, steroids are safe, but you will still have to deign and submit and defer to the expert opinion of the obstetrician, because he's watching an unborn child. I hope you are with me together. So there has to be a lot of collaboration. That's the point I'm making. We can't just sit down in our consulting room and say, let the patient come. This is one thing where we'll have to sit down together and say, what are we going to do? How are we going to deal with this patient? And have some kind of, even if it's a virtual conference with all the other specialists. And they say, what am I afraid of? I'm afraid of her losing her vision. And he says, oh, I'm afraid of her losing her baby. So where do we meet? At what point do we meet? Okay, do we allow this woman to just cross the first trimester where we know that organogenesis is complete, and let's see what we can do at the second trimester? So I think that, you know, I might not have a pat answer for that. Yes, the books say you can do this and we can do that, but at the end of the day, you know, we do not make light of the fact that we are dealing with a disease that needs multidisciplinary specialist care.
Yeah, thank you very much. That's well noted. So the other thing is that somebody would want to know about the role of genetics, the diet and geographic location as per the disease. Okay. Genetic studies have been done for the risk factor, for the risk of the disease. You know,
yes, they have been setting genes and alleles and HLA typings that have found to carry specific markers, you know, and these are all in the etiopathogenesis, you know, of the disease. However, talking about geographical location, there are areas now everybody talks about, food fortification, iodinization of food, salt, sugar, and the like. In years gone by, it had been talked about areas that lived in high mountainous areas where you had leaching, of iodine on the top soil surface. But those areas are no longer subject to such things now because there's fortification. You understand? So what about we're now talking about other mechanisms which could cause damage, no longer by the fact that you are living in an area you are prone to this. The other things that could now be involved in the etiologies of thyroid eye disease. There's still a lot of studies going on. I must be honest with you. However, just as I've put it across to you, treatments, a lot of things are still being developed, so we can't say specifically, we found it's located in chromosome 2 or chromosome 5 or chromosome, as the case may be. Perhaps in the next couple of years, we might be talking more confidently about that, and that's important because for now, we can't really say, we'll do this kind of intervention, just like maybe you have in retinoblastoma, if you can do this, you can avoid it and the like, but not that I'm aware of a lot of studies going on, but conclusive reports to guide us with our therapy, one cannot conclusively say that for now. I'm seeing a question that says, patients' refusal of treatment, especially steroid therapy. Patients refusing steroid therapy. Well, I have not had so many patients I've had to do that. I've seen a lot of thyroid patients in the past few months. But incidentally, I have not met since the beginning of this year, I have not seen anyone who I deemed as a clinically active patient. I always had a clinical activity score of 0, 1, maximum 2. So I have not had to institute steroids in the past, in the recent couple of months, up to the recent year. Perhaps somebody might want to give me the experience on that, perhaps Dr. Bola, so I've seen them. So that's where the follow-up comes. I now have to follow up the patient. Am I seeing a patient who is in the ascending phase of the disease, like a patient I saw a few weeks ago? Are you in the ascending phase? And perhaps if I follow you up, and you are not active now, perhaps in the next 6 months you may become active. Or am I seeing a patient who is at the bottom phase of his disease? You understand? So if I have not had to give steroids to anybody for thyroid eye in the last couple of months, is because the patients I have seen have all been clinically inactive. So there was no indication for that for now.
Okay.
Thank you. Can I come in, Dr. Allen, as you invited?
Yes, ma'am.
Thank you very much once again. Actually, like you said, clinical activity score.
Yes, go ahead, ma'am.
You can't hear me?
Yes, we can hear you. Please go ahead.
Okay. So I said, actually, like Dr. Allen said, most of our patients so far in the study have actually belonged to the low clinical activity score. So that's our general experience. And then in terms of patients refusing therapy, especially steroid therapy, patients are very well aware now of the side effect of steroids. So even with your explanation, they are very afraid. We've even had doctors who disappeared from the clinic at hearing that we want to put you on steroid therapy. So that has been our own experience. And we've had an elderly woman who refused steroid therapy, though a known glaucoma patient in advanced stage, and this woman waited to go blind. So that's why I wanted to know your experience. And then you also find some of the young patients, they say, I'm putting on weight, I'm getting fat, I don't want to continue with this treatment. That's why I wanted to know if you have similar experiences as we do.
I've not had that. The patients whom I've had, the more common patients for the orbit treatment that I've had to give steroids, incidentally, are patients that I've seen with orbit optic neuritis, who will give a much shorter course of steroids, and generally they, they're not averse to it, perhaps because it's a much shorter course.
Of course, yes.
Yes.
Most probably. Thank you.
Thank you, ma'am.
Okay. Thank you so much, Ma. There was also a question about the geographic location, but I think maybe the study,
Incidentally, there has been through all the literature I looked at, there has actually been no predilection. For example, the way you say at Terrigium, you have a so and so degrees latitude and all that. There's actually been no predilection. What you actually see as patients that you are likely to see presenting as was are when you have patients who are older, patients who are male. They are the ones that you tend to see them with a very angry thyroid eye disease and all that. But as per geographical locations having the advantage or disadvantage, of having more of this, I've really not had to see areas that are disease specific or more likely, perhaps if we had to now look at our nutritional status, perhaps we might actually see that there may be a borderline maybe deficiency or something, and these are things that are interesting to be looked into and are waiting for us to look into them.
Can I come in, please?
Yes, ma'am.
Thanks so much once again. My reason for asking that question, I come from a part of the country, very rocky, next to Abeokuta. I don't even know if we have more rocks than Abeokuta. And in those days, thyroid, goiter, big neck was more or less like a norm in my community. And you see, parents have it, their children have it. But now, luckily, with iodine substitute in our diet, that has reduced. So that's my own experience with thyroid.
Ma, you're very correct.
Geographical location.
Ma, you're very correct. I schooled in Uniben, and they told us about a thyroid belt when we were in medical school, talked about a thyroid belt. And then the thyroid belt spanned across the then Edo North.
Yes,
Edo North, middle belt, where, yes, currently Kogi State, Benue State, Edo North, that's belts around straddling that area, straddling the confluence of the Niger, and it was so apt because every patient that we saw with a goiter came from those areas, you understand? But so, and of course, and we found out that patients that were not from those areas by birth lived there or had spent a significant part of their youth in those areas, you understand? So I think that the programs that we're talking about, the fortification, iodine fortification and the like of foods that had gone past in the several decades have done a lot of work,
That's true.
Yes. So even if there were no genetic inference, somebody who had lived, his parents had lived there, he has lived there, were exposed to the same leaching. What happened then was that iodine was leached up the top surface of the soil. So plants that were grown and all that, things generally were deficient and all that, people lived off the soil. Now that a lot of those things are no longer, people are no longer dependent, necessarily on foods from their local, and we have a lot of fortification. As simple as it is, that has done a lot. And so we're now looking at other causes and other etiologies, and now perhaps the risk factors that were waiting in the wings maybe have gained more importance now, perhaps.
Thanks so much.
Thank you very much. We are still here, moderator. We are still here. Am I audible?
Very well, ma.
We are still here, moderator.
So, while okay, the moderator is back. We can hear you. Okay, I think
I said
is Ori. So I'll just take over. So there was a comment in the chat box saying that it is very important to specifically counsel ophthalmologists on administration of IVMP in conjunction with the physician, and you have clearly stressed that. Thank you, ma. Also, another comment on selenium is said to be known to be beneficial at the early stage of thyroid eye disease only.
Oh yes, they said it is. That's what we indicated here. Mild disease. Yes. Mild disease.
Okay, so this question came on, and the person is asking, can you throw more light on the use of steroids in a pregnant patient with TED? the dose and what stage of pregnancy can it be used?
Yes.
Thank you. Thank you. So let's first of all, at what stage do we use steroids? We use steroids for mild to moderate active disease. So first of all, ascertain the patient. Is the patient active? Is the patient mild or sorry, we use steroids for moderate to severe. We don't use steroids for mild, moderate to severe, or sight-threatening loss. Just like in any condition, when you are dealing with pregnancy, it is thought that they respond. In the literature, we have it. Yes, you know, I have not had to manage a pregnant patient for thyroid, for significant thyroid eye disease. It's thought in the literature that they respond. You understand? You know, so the problem now is not do they respond. The problem is the risk of giving high dose steroids to a pregnant woman. First of all, just like any other drug, you want to avoid therapy of anything in the first trimester. The obstetrician will not allow that. So now that's where, like I mentioned, that there are no dosage adjustments. If I may come into that, there are no dosage adjustments. For the biologicals, there are some of them that are contraindicated. There are no dosage adjustments. You know, if a patient comes in and she has sight-threatening loss, I should be able to plead my case to the obstetrician. But if the patient comes and has having a potentially malformed baby. So those are the things that, you know, you have to sit down and you can't, the point I try to make is to make it clear that we cannot just sit down in our consulting room, write a treatment to the patient, tell the patient, bye, go and see so and doctor, so and so. We have passed that as far as it's thyroid. The patient is at the center of the care. The doctors are linked together. That's what this picture shows. It's not just that the doctors are linked together. So if I source that kind of patient, I will put a call to the obstetrician and I must arrange a meeting with the obstetrician. What are the things, what am I thinking of? What are the things at risk? Are you following me? A patient who is 7 weeks pregnant is not the same patient who is 38 weeks pregnant, you know? A patient who is in early trimester is not the same patient who is at mid-trimester. Are you following me? So yes, in as much as I know that she will have good response, you want to consider, does this patient deserve the immunosuppression I'm giving her? You know, is the disease mild? Is the disease moderate? Is the disease sight-threatening? Then I can have my case. You understand? Is the disease active? Supposing she comes in and she's mild to moderate and she's inactive. If it's mild to moderate as an inactive, you don't need to give immunosuppression. If she's mild to moderate and she's if she's moderate to severe and she's inactive, she doesn't need immunosuppression. If she's moderate to severe and she's active, then I say, okay, obstetrician, this is what I need to do. I have my dosage regimen ready, and we might have to have a balance based on the other medical issues that the patient will have in pregnancy. So I don't think we should just sit down and say, is a one-off answer. No, yes, we know the patient will respond. But remember, we don't want a patient who will have a mortality at the risk of we're trying to save her eye, which is what the obstetrician is thinking of. So more than ever before, we have to emphasize the interplay and the interdependency of the various multidisciplinary specialists attending to this patient. You understand? We have to, in some institutions, you actually have them coming together, you understand, and having something like we call it a conference or something for each individual patient. What do we do? Where do we go? What do we do for this patient? And I think that for the pregnant patient, this cannot be, we can't expect anything less than this, you know. So this is my take. Okay.
A bit of contribution, please, if you don't mind.
Yes, ma'am.
Actually, from my little experience with thyroid in pregnancy,
please go ahead.
From my little experience with thyroid in pregnancy, it tends to abate. The major complaints or challenges they then have really is the proptosis, which we can manage conservatively at that stage. Thyroid patients, sometimes they also have challenges when they come in the early, that's shortly after delivery. They tend to come fulminant. Some of them come fulminant shortly after delivery. And we are now between the devil and the DHC. Do we give this nursing mother steroids who is breastfeeding? So at that stage, if it's severe and we have to treat this woman, then we have to wean that child off breast milk so that the mother can be treated.
Yeah.
That's
at that point, yes, at that point in time, thank you, ma. Thank you, ma. You're very I think I agree with you very strongly, because at that point in time, you have an option. The child is no longer in utero. You understand? And if she cannot breastfeed, there's still another option. A child can be bottle fed successfully. You understand? Which is a different consideration from if you, and you just like you're correct. You know, some of these conditions, just like migraine and they tend to change their pattern in pregnancy. But just imagine the patient came in at pregnancy, you know, and there's no other option. The baby is in utero. There's no other option for the baby. The baby is not going to come out and go back inside, you know, unlike what you have when she's nursing and you have another option for feeding. So I want to agree with you. But like, you know, even with that baby feeding, you know, even with that baby, you understand, the mother breastfeeding, I will still have to relate with the pediatrician. Counseling to understand why she will not secretly go and attempt to breastfeed, you know, to have expression of the steroids in breast milk. She will not secretly go, and she's working with us in tandem with us, knowing what we are trying to do. And of course, you know, the cultural issues that come in. Oh, she's not able to breastfeed and all that, and feels very guilty, and maybe issues with in-laws and relatives and all that. So she needs a lot of counseling at that point, so which the ophthalmologist at that point may not be able to do. Remember, the pediatricians have a lot of issues with women. They have a lot of patients who, for one reason or the other, even if they promote breastfeeding, they have a lot of patients who, for one reason or the other, are advised not to breastfeed. So they are more experience with that kind of counseling a patient who will not breastfeed. So I will defer to them a lot concerning this and say, I need to place this patient on this, but this is what is going to happen. So I can't overemphasize it, the need for us to have a good multidisciplinary approach to it, and to see other specialists are not just peripheral, you know, to the treatment, but as an integral part, you know, of the treatment that this patient we have to get at any point, you know, of the disease. That's my point.
Okay, thank you very much, ma. So the final question for today will be, do you use oral steroids, or is just IV methylprednisolone?
For which? A lot of for what we talked about. I mentioned several points in the disease. I mentioned active. So sorry, I keep saying for moderate to severe active disease, it has been found that, sorry, my slide is not okay. For moderate to severe active disease, this treatment regimen came as a result of a lot of randomized clinical trials, you know, for several combinations of therapy. As they found that the best results are got with intravenous use. Incidentally, the side effects like osteoporosis and the leg are actually less with this than with oral steroids at the same dose. So for this is intravenous steroids. However, in a few cases, oral steroids do come in. For example, look at this. When a patient who for some reason or the other needs to be on second line treatment, maybe there was no response to IV, or there was a contraindication to IV at the first place. So patient who is undergoing radiotherapy for active moderate to severe as a second line treatment, look at it, oral steroid is synergistic with radiotherapy. A patient who has to be on cyclosporine, oral steroid is synergistic to it. However, these are second line and drugs, okay? So there's a role for oral steroids as a synergy to some of these other second line drugs, yeah. And of course, for this thyroid optic neuropathy, for sight-threatening loss, you know, this treatment regimen is born out of a lot of randomized controlled trials, and oral steroids do not have a place here. It's strictly intravenous.
Okay, thank you very much, ma. Hello?
I'm with you.
Audible.
I'm with you. I'm with you.
Hello?
Am I audible? Wow.
You're audible, ma'am.
Hello?
Yes, I can hear the moderator. Looks like she's probably
Hello?
lost.
Am I audible?
Very well.
Okay.
Very well.
Okay. All right. Thank you so. Okay. Thank you. Okay. Thank you very much, ma'am, for doing brilliant justice to all the questions. And thank you for taking time out to give us such a brilliant and very extensive presentation. I would like to also acknowledge some of our colleagues, senior colleagues actually, that are present here. Dr. B.G. Balogun. Hello?
Yeah.
Hello, Doc. Hello?
We can hear you, please.
Okay, I would like to acknowledge some of our senior colleagues present here, Dr. B.G. Balogun, Professor Adio, Dr. Ngugu, Dr. Ariman, Dr. Megbelein, and others that I've not been able to identify. I want to say a very big thank you for finding time out to join us at this very interesting presentation. I also want to thank everyone taking time to participate and sharing questions. I would like to call on the chairman of the Young Ophthalmology Forum. That is Dr. Ugochukwu Eze, to give us the final closing remarks and end the meeting. Thank you so much.
Thank you very much, dear moderator. Thank you for a good job you've done today. Thank you, Dr. Allen. We appreciate you so much. You've kept us glued to our devices for the past 2 hours. It was never a dull moment. We appreciate this. Thank you very much for the justice done. Thank you all our participants. A lot of participants have left, but we appreciate everybody that's made this day successful. Without those that attended, we wouldn't have had a great day. I appreciate thank you for the YOF academic team who did a lot of work on that. We appreciate all. On this note, we would like to end this meeting, and I wish all of us a very pleasant evening rest and a very rewarding week ahead.
Thank you.
Thank you. Have a nice day.
Thank you. Thank you so much.
Thank you. Thank you, everyone.
Thank you.
Thank you.